pulmonary TB. They specified pulmonary because tuberculosis can infect other body parts such as the joint, the heart, other organs as well. So this chapter will only discuss diagnosis and management of pulmonary tuberculosis. You should be familiar with this disorder. We screen you for it every year. This will continue during your employment as long as you stay employed in a healthcare area. You will be required to be tested for TB, both because it's highly infectious and you are constantly exposed to it. And we typically don't screen all patients for TB, only those that manifest symptoms. And usually they don't manifest symptoms all the time. So what if the symptoms come during the admission, which at that point, all of us have already been exposed, correct? So we need both your diagnosis. We need to diagnose if you have pulmonary TB or not. And then if you do, then we will treat you. So it's a worldwide problem. As the world got smaller, by saying that, I mean travel is now very easy between countries. So immigrants like myself have brought tuberculosis into this country. It's highly communicable, transmitted through simply breathing the same air, for instance, exactly where we are now. If someone in here has active TB, then we are all exposed already. Does that mean though that we are all infected? Not necessarily. So this is an infection concept, correct? So let's review what are the concepts or the 6 chains in the chain of infection. What are the 6 links? Sorry. Okay, we need the not yet. We need the organism first, right? So this is the organism. So Mycobacterium tuberculosis. There are other strains of TB, but for this chapter again, we're talking about that strain, Mycobacterium tuberculosis. Next, after the positive organism. Go ahead. Okay, so we have a reservoir. Okay, the reservoir, does it have to be a living organism? No. Reservoir can be a person or it could be a infected surface or object. Next. Okay, exit and entry are the same, correct? So that organism must leave that reservoir. Again, that reservoir could be a living person or an object. So it has to leave that reservoir and then, okay, and then the organism will enter another host via the portal of entry, correct? Again, portals of entry and portals of exit are the same. What are they? Okay, any opening in our body. So that could be our eyes, nose, mouth, ears, genitals, the rectum, and well, as far as the skin, it's really very rare that we have, except for, let's say, chicken pox, right? But chicken pox is also airborne, correct? Okay, so and as well as measles. So we've got those 4 so far, and then number 5 is the mode of transmission. How is it transmitted? Do I have to touch the patient? Do I have to get in contact or a certain distance from the patient, okay, in order to contract the disorder? Or do I simply have to breathe? Since this is airborne, that means how small are the organisms? Only between 1 to 5 micromillimeters in diameter. Okay, that small. So small that they can be carried through the air and they'll linger through the air over a long period of time. And that can be spread through talking. That's what I'm doing now. Talking, coughing, sneezing, laughing, or singing. And then finally, we have the susceptible host. So next question we'll answer is, who are the susceptible hosts? These are the susceptible hosts. Chart 19-10. First is anyone with close contact with active TB. We specify active TB because if you have passive or inactive or also called latent TB, you cannot transmit the disorder. I got infected with TB. My infection was inactive or latent TB. So I didn't have symptoms, so was I contagious? Do I have the option to receive treatment? Yes. So I got treatment. Why not? Why won't I just treat it? So I treated it. I'm good now. Next is immunocompromised people. Those with HIV, cancer, transplant recipients, or on long-term IV steroid, or not necessarily IV, long-term steroid therapy, whether IV or by mouth. Substance abuse disorder. Now, this does not mean that you contract TB via the IV route. No, you still contract TB via the airborne route. All this means is substance abusers. What kind of judgment do they have? No. And usually, who do they hang out with? Okay, so usually they don't make the best decisions. Okay, they make when they're under the influence, whether alcohol or other substances, they hang out with people who are not really the healthiest, okay, or not really in the best environments. Let's put it that way. So anyone in healthcare without adequate healthcare. So these are people who we've never tested. They don't see a primary healthcare provider or don't even go to public health facilities. Or very young, especially minorities. That means they're immigrants as well. Pre-existing medical conditions. So does this include our dialysis patients? Okay, so these people we mentioned here on the second bullet. And those receiving long-term care, let's say they're either institutionalized, in a nursing home, rehab facility, prisons, mental health facilities, okay, or shelters, okay, because these places tend to be what? Okay, crowded, right? And then they congregate in common areas. Immigrants from where? These countries right here. Okay, so I'm there. I'm in Asia. We have people from various African countries here, also South America and Caribbeans. Okay, so New York City is a very good cesspool for tuberculosis. Okay, because everybody's here. I already mentioned institutionalized patients, and you can understand this is also that bullet, living in overcrowded places. That is usually again where the most of our drug and substance abusers live or hang out. You're on the same page with me, right? Because if this fails today, then I can't show it anymore. And finally, being a healthcare worker. So are you healthcare workers? Even if you're not working as a healthcare professional, you have been exposed already because you are going to the nursing home and hospitals for clinical. Right, so that's the risk factors. Next thing is there's another chart, 19-11. These are the recommendations. So we follow CDC recommendations. So all employers will require TB testing. We'll discuss the options for TB testing and the results shortly. Signs and symptoms. Then we'll go to the diagnostic testing. these are the manifestations. If you have the manifestations. So if you are infected, you have an active infection, you will show these manifestations. Doesn't have to be all, but a few. Now, these symptoms are not just a few days. Okay, so these are 1 month or several months in duration up until the patient seeks provider consultation until they get diagnosed. So non-productive or productive cough, which the sputum could be blood tinged or you could be mucopurulent, meaning it has pus in it. Hemoptysis is the term for blood in the sputum. Let's go now to the skin testing. Now, I know most of you do not do skin testing anymore because you prefer the quantiferon gold, right? It's less painful because you only have a 1 needle stick and it's IV drawn intravenously. And whereas this one is embedded, planted in the skin, correct? So it's way too painful and you have to do this every year. Now, for the results, your textbook does not give you the information on results because the CDC will update the results periodically. So let's go to CDC. It's quite easy. So just go to CDC, type in the search as CDC PPD interpretation. That should give you a hit on the fact sheet. All right, this will be the first hit you'll see. Fact sheet, TB, tuberculous skin testing. Open that. And then scroll down to so I open that link, then scroll down here to the results. Okay. There are 3 columns here. We divide people into 3. Each column is positive. What's the difference between induration and redness? Meaning here on figure 19-3, page whatever this 548. What do we measure, the redness or the induration? Okay. Induration. What is induration? The raised area. Okay, so the raised area is the induration. How big is the raised area? Not the area of redness. For example, so when we first came here, there were 7 of us on the same plane. One of us, when we got our PPD, the entire arm from the wrist all the way to the armpit turned red. There was no induration though. There was no swelling. There was just redness, like really red. That was still a negative reaction because was there any induration? No. Typically, when that happens, the individual just reacted to some of the components or ingredients of the, what do we call the PPD? The purified toxin derivative, right? Okay. So we just reacted to one of the components there, one of the ingredients, okay? So what do we measure again? The induration, okay, or the raised area. So a PPD result of 5 or more, induration of 5 or more is positive in these patients right here. HIV, immunocompromised, or those who live with people with active TB. Okay, so let's say your dad has active TB, you live in the same house, so you're under 5. Any question? All right. An induration of 10 or more is positive in these patients here. So we've got immigrants. The immigration here must be within the last 5 years. If you've been here more than 5 years, that doesn't count anymore. Should be recent. So drug abusers, people who work in the microbiology department because they're the ones handling the specimens. People who live or work. So if you work in a hospital or a nursing home or live there, you're a patient there. And then again, people with certain medical conditions. These were again mentioned in chart 19-10, correct? Okay. And then very old or very young, children under 5, or malnourished patients. And then finally, 15 or more in duration is positive for the rest of the population that are neither under 5 or under 10. Okay, meaning these people listed here in the 5 and 10 millimeter groups. Any question? So if I ask you, what must your PPD result be in order to be positive? You guys.
15 or greater.
You wish.
No, us is 10.
Oh, healthcare worker, 5.
You guys are 10. You're not 5. Because are you living with people with active TB? Like, do you sleep with someone with active TB? No, with that close?
Okay.
Well, are your partners having these manifestations here? Do they have fever, night sweats, cough for more than a month? Okay, if not, then they don't have TB, all right? Even if they do, it's not contagious because are they symptomatic? No, you have to be symptomatic. Okay. So this repeats again, clinical manifestation. So let's go now to the testing. So we just discussed the tuberculin. So we were going to plant PPD, purified protein derivative. We plant that 0.1 mLs in under the skin. Then we read it at 48 and 72 hours, correct? I mean, you should be familiar with this, unless who has never had a PPD here? Okay, so everybody experienced it. Okay. So that's the standard and cheapest way to test for TB. The problem with this test is if the patient received a BCG vaccine from those countries mentioned earlier, from these countries we mentioned in 19-10, immigrants from these countries. So newborns from these countries are automatically given the BCG vaccine. It's a vaccine to prevent tuberculosis because we understand tuberculosis is everywhere. And one of the risk factors again is what? Children under 5, right? So very young children, which is where newborns fall, are they at risk for TB? Yes, so we protect the newborns by giving them the BCG vaccine. Now, when you get a BCG vaccine and it's given within 10 years of testing, it may result in a false positive, meaning you reacted to the vaccine, meaning you were given the organism, okay, a weakened form of the organism. So it's in your bloodstream, okay? So it's in your blood. So when we give you PPD, of course you will turn positive, but that doesn't mean you were exposed necessarily, right? Because we gave you the vaccine. However, if at least 10 years or more has passed since the BCG vaccine has been given, latest evidence shows that if it's more than 10 years since the BCG vaccine and you turn positive on PPD, you most likely have been exposed already. All right, it's no longer caused by the BCG. Okay, that's the latest evidence. Are we clear? So therefore, if you test positive for PPD, how do we, and you're not sure, okay, so let's say you insist, oh no, I can't be, I must have been, it must have been, it must be a false positive. So if you don't agree with your result, what do? We will give you, no, not necessarily, we'll give you a quantiferin. This test is not affected or influenced by the BCG vaccine, meaning You test positive and you don't agree with your result. So the doctor may say, your PCP may say, okay, let's do a quantiferon. Quantiferon will confirm whether or not that false positive, or if it is a false positive, is caused by the BCG or not. So if you're positive here, what is this test again? Is this going to be influenced by prior BCG vaccination? No. If you're positive here, you definitely have been exposed to TB. The other tests are, we have the T-spot, which is an older test, but the two most common, of course, are the PPD and the quantiferon gold. Okay. Now, let's go back here. Take note that, what did I mention? What does a positive test result mean, whether it's PPD or quantiferon? What term did I use? You have been exposed, right? Take note that I did not say you're infected with TB. What did I say? You've been exposed to TB, okay? So neither test will confirm whether or not you are infected. Just means, what does either test do? You've been exposed to TB, okay? So next thing the doctor will do is, if you have a positive test, then we'll look at the symptoms, okay? Do you have symptoms? If you don't have symptoms, then what's your diagnosis? You have TB, but it is inactive. It is latent. It's not active. You have no symptoms. So are you contagious? No. You will be offered treatment though. Just like I was offered treatment. Okay, so they will recommend. Okay, we recommend you take 1 or 2 drugs. Okay, so rifampin or INH for typically 6 months. Okay. So it's up to you if you want to get treated or not, because the risk is, if you don't think you need treatment, you're healthy right now, correct? And you recognize you have the infection in you. You're just not symptomatic because you are healthy. Your immune system is able to keep the disease in check. Are you going to be healthy forever? Are you going to grow old? Okay, so will your risk factor change? Will you now fall under chart 19-10? Yes, so now your age, right? Or let's say you develop a chronic condition. You end up on dialysis, or you become really bad diabetic, for instance, all right? Or you have organ transplant. So now will the disease now infect you enough to make you sick? Yes, it will be activated now. So you have a choice. It's there. Why not kill it? Yeah. So that's what I did. So I took the treatment. Now I'm okay. Yeah. Yes.
For how long it could stay without treatment?
You mean?
The positive test. So
Well, it will always be positive. Like for me, even if I was treated, well, the antibody is already there. So therefore, every time I get PPD, it will always be positive. But I don't have to get PPD anymore. Doesn't make sense. So all I'll require is a chest X-ray. All the hospital or my employer will require is, am I still symptom free?
So after treatment,
It's just an actual,
blood
yep,
work would be positive.
yep, because the antibodies are there.
So after that person who isolated the opposite of the treatment, they will still show.
Yeah, remember, because you were exposed.
Oh.
Okay, but you already killed it though. Okay, there's no way it can infect you anymore. Okay, so all that's required is chest X-rays. We'll just monitor you every few years. Okay, are you still symptom free? Are you still negative?
So it could start anytime after like a year or 2 if it's latent stage.
Latent, yes. Think about it this way: the organism will just wait patiently. Okay, they have all the time in the world. Okay, they'll just wait patiently there and then see. Okay, when's a good time? Okay, no more soldiers. Ah, there's a lot of soldiers. There's no way. We can't win. Okay, they'll just wait until the host is immunocompromised, then they'll strike. Okay. So what will confirm an active TB infection? So let's say you have the symptoms, right? The low-grade fever, cough, fever, night sweats, weight loss. Then we will get a sputum culture. This will confirm the diagnosis along with a chest x-ray. However, if it's early in the disease, the x-ray may not show anything wrong, but the sputum will. Sputum will show the active organism. So we see the evidence there, it's confirmed you have TB, okay? We saw it in your sputum.
So would the
Right.
sputum be positive? Definitely.
No.
Only. if you
Only
have
active, yeah. Only active infections will show a positive sputum culture.
What if you got treated? Then it will show up negative?
Nothing, because again, in the first place, you're already treated. Which is what we'll do with when we evaluate later. At the end of treatment, we will ask for another sputum culture to see did the treatment work. Okay, management. It's only managed through drug therapy. For drug therapy, here's your table. There are 4 drugs. Now, this table will only address this type of TB. So first line anti-TB for active disease. This will not apply if it's a different strain, let's say different other than Mycobacterium tuberculosis. If you have a different strain, we'll give you different treatments. Okay, this is only for the most common, which is Mycobacterium tuberculosis. Now, before we get to the side effects, let's do the how is this given, because it's important to understand so that you can explain it to your patients. Because who are these patients that will have active TB? IV drug users, homeless people, right? Okay, so alcoholics. So are they going to be like you and me, wherein you give them a prescription? Here you go, sir. Follow that, okay? Very good, all right? No, these patients will be challenging, okay? So they need to understand how long the treatment is and how many drugs. Okay, it's written here. There are 2 phases in the treatment. I'm on page 550. We call the first phase initial treatment phase, and then the next phase will be continuation. First phase is about 8 weeks. First phase, 8 weeks. The continuation phase is 18 weeks. So how many weeks total? 26 weeks. That's about 6.5 months, right? Okay. So 2 phases, 8 weeks initial, 18 weeks for continuation. Okay, take note, what is this guideline again? For what type of TB? Active, okay, this one. Primary active, meaning the most common type, which is Mycobacterium tuberculosis. Okay. For other strains, it would be longer. It could be 12 months, it could be 18 months, it could be 2 years, or even longer. Now, look at the treatment. Why 4 antibiotics? What does that tell you about this organism?
It's resistant to drug therapy.
It's pretty badass, right? I mean, you need 4 drugs, 4 strong antibiotics to treat it. So that tells us a lot. This organism is not some puny, bacterium. Okay, this is pretty strong. So we need to use 4 antibiotics to treat it. How is it given? So we said first phase, first initial phase, and then continuation phase. So for 8 weeks, you will receive 4 doses. Right here, initial treatment, 4 doses for 8 weeks. So all those 4 drugs listed in table 19-4, table 19-4, we're giving for 8 weeks, all 4. All 4 for 8 weeks. On the continuation phase, we will drop down to INH and rifampin only. Only 2. Yeah, again. How many for 8 weeks?
4.
All 4. INH, rifampin, ethambutol, and PZA, pyrazinamide. All 4. The next 18 weeks, down to 2. Does that sound better? Yes. To me, if I'm an alcoholic, okay, I can do that for big pills for 2 months, and then down to 18 weeks. All right, let's do this. Okay. Now, if the patient is especially challenging, let's say he's a homeless person, where are you going to send the prescription and how are you going to surveil the patient? Because they have to be under surveillance. When we say surveillance, they're not like 24-hour surveillance, okay? There won't be a camera or a task force, like a team of cops watching. That's not what we mean. We mean surveillance as in we check them, okay, for drug compliance, okay? And then we'll check them later at the end of therapy, whether they're treated or not. Because is this serious?
Yeah.
Do you want these people riding the subway and then untreated and then infecting everybody? Of course not, right? And these are all free, by the way. When you get these medications, let's say you were treated, this is all free. Even the testing is free. The lab work is free. These are all paid by tax dollars. Do you mind? Of course you won't mind, because would you rather, again, these people untreated infecting your family members or yourself? No, we don't want this thing spreading. So it's okay, right? I'll be gladly paying for this with my taxes. Now, let's go now to the table. What are the side effects? INH, peripheral neuritis, meaning does it damage or harm your nerves? Yes, harms your liver. Because of this, to prevent the neuritis, the nerve injury, you're going to be given B6, pyridoxine, to replenish your B6 stores, because this drug will deplete your B6 levels in the liver. So when you're taking this drug, you will be prescribed B6. All right. We're on the first one, INH. All right. And then because it's harmful to the liver, monthly, every month, we will monitor your liver enzymes. Any questions on number 1? Number 2 drug, rifampin, also harmful to the liver, causes hepatitis. So what are the side effects? This drug will turn your orange and other body secretions. No, it will turn your urine and other body secretions orange color. Is this harmful?
Yeah.
No. This is expected. This is a harmless side effect. Are we clear? Okay, this will just stain your, what else besides your urine? Tears, saliva, reproductive secretions, all turn orange. Anything wet coming out of you, except sweat, okay? Sweat will not turn orange, okay? So just the tears, saliva, reproductive secretions, and urine. So it can discolor contact lenses. And because, again, it's harmful to the liver, you monitor your liver enzymes. Any question on number 2? All right, let's go to number 3. We'll skip these because these are just other forms of the drug. Let's go to PZA. Pyrazinamide causes hyperuricemia, high uric acid. So this is like gout, right? You know anyone with gout? Okay, so the patient may develop gout symptoms. So what do you think will help to minimize the formation of gout? Okay, you can do the diet, meaning avoid high purine foods. You will talk about gout in your last module. But pretty much anything that has high purine include shellfish. You know what shellfish is, all right?
Yep.
No, clams, shrimps, lobster. Not just not just shellfish, but what do you call them? Crustaceans, right? Okay, so those will be high in purine. Meats, red meats. Okay, so what are red meats? Okay, beef especially, right? Okay, so those are the high purine foods. Nuts also. Nuts are high in purine. I noticed all my Muslim friends, almost all of them have gout. Back home or here, doesn't matter which country. The diet is the same, I guess, because they eat a lot of beef, right? Yeah, especially, after Ramadan, when they have these parties, yeah. So they eat a little too much red meat and then they pay the next day, right? One of my friends owns is a mechanic, so I go to him frequently, and I know when the shop is closed. Okay, and I know the date. Yesterday was celebration. Shop's closed because I know he's in bed nursing his big toe. Okay,
Yes.
so increase fluids, right? Can you do that? Okay, so we can encourage them to increase fluids while on that drug. And then finally, ethambutol. Now, this is the only drug that doesn't have any, you notice it doesn't have any liver damage, right? So PCA also mentions on top of the hyperuricemia, you also have hepatotoxicity here. So still harmful to the liver. So you still monitor AST, ALT. But in ethambutol, nothing there is mentioned. It just says it does harm what? The eyes, causes optic neuritis, can lead to blindness. So therefore, it tells you here, the patient must therefore have a baseline eye exam before starting the drug so that we can see whether or not there are changes during therapy. Okay. One thing not mentioned here is, although yes, the drug is not known to cause liver toxicity. However, when you take this drug with alcohol, it will cause severe nausea vomiting. Like it will cause you to never touch alcohol again. It's that severe, right? Like non-stop vomiting. You've vomited before, right? Like you have hangover and then you got vomiting. You remember the feeling wherein your diaphragm here is so painful that you cannot, it's hard to breathe, hard to move. Okay, so imagine that every day. Okay, so if you touch alcohol, by touch I mean you drink alcohol, okay, while taking ethambutol, you'll regret it. You'll be deathly vomiting, violently vomiting. So all four drugs given to a IV drug user who may or may not be an alcoholic, is it easy?
No.
So will we have plenty of non-compliance here? Very frequently. So we already know that. So we have a technique, a strategy to ensure compliance is we call it DOT. We have that tech strategy came from the third world, the countries we mentioned earlier from Asia, Caribbean, Africa. So it came from those countries because they've been treating TB for the longest time besides North America. So what they do is do the strategy of DOT, direct observed therapy. That means these patients will have to come to for supervised treatment. They don't have to be institutionalized, meaning you don't have to put them in a nursing home or rehab or some prison. Okay, they go to so the CDC will ask any local provider. Okay, it could be some health department or a private practitioner. So they'll assume responsibility over the treatment. Okay, so we'll take this case. Of course, the government will pay them. So the patient will come every day for their pills. They come in, okay, here are your pills. Say, okay, good. See you tomorrow. Okay. So to ensure that, we give them allowances. Okay, here, a meal voucher for your trouble. Here's some Metro cards, okay, for to travel here. So you give them everything they need to go. Okay, so all they need is just their time. Okay, to go there. There's no hassle here. I'm giving you a bus ride or a train ride. Okay, and here's a meal. Okay, just for you to come and take your pills. Right.
COVID first started, like, let's say you test positive, they'll keep calling, is it something similar? Like, they'll keep
Yes.
calling your phone
Uh-huh.
to make sure that.
Yeah, that's what surveillance entails. Yes, ma'am.
In order to take out,
Again, the CDC will identify anyone within wherever that patient's community is. So they'll identify a provider, then ask them, hey, can you take care of this patient for TB? They already know the protocol. Okay. So what happens if the patient doesn't comply with treatment? Are they still infected? Are they communicable? Okay, so we won't go into drastic measures of arresting them, nothing like that. However, we can. Okay, so the CDC has police power. So they can suspend an individual's civil rights, meaning the right to travel. So they will be forced to be in a facility. They will be forced in an institution if they don't comply with treatment because they are endangering society. So in those rare cases, do we have those patients? Yes, we do. But they eventually come to the senses. They say, "What the hell am I doing? Just give me the damn pills." All right, because it's a hassle. Okay, because again, they're told, "Sir, we have to treat you. Okay, this can't be. You have to be treated." Next question is, well, how long will they have to observe the isolation? Not for the entire 6 months or 12 months. Okay, so here's the answer to that. People are considered non-infectious after 2 to 3 weeks of continuous medication therapy. You understand? So meaning, yes, if I have active TB, do I have to isolate for 6 months? No. What happens to my family members that have been exposed to me? We do the same thing. We test them. If they're positive, we offer the same treatment. You understand? Okay, as simple as that. Again, they can now leave, meaning they don't have to wear a mask. They can go back to shopping or grocery, going back outside after. What's the minimum? 2 weeks. So if I take the drug for 2 weeks, it's okay. I can go out of the house. I don't have to be afraid of infecting people, right? But do I stop the treatment though? I should finish the 6 months or 12 months, whatever is prescribed. Because what do I risk happening if I stop in the middle? Could I create what? A multi-drug resistant organism now. So now I will end up with even longer treatment, more alcohol abstinence. Because here, when I got the treatment for 6 months, so I started around November, I think, November when I was diagnosed, and then 6 months would be up to April, right? So I missed drinking during what? Thanksgiving, Christmas, New Year's. All my family members have, no, 2 of my kids have April birthdays. Mine and my wife's are March. Okay. And then I had another daughter December birthday. Okay, so no alcohol during those times. Okay, so the toughest 6 months of my life, no alcohol.
After that, you don't have to restrict yourself no more.
Yeah, I partied afterwards.
I bet you did.
Yeah. I ended up under the bridge. I woke up under the bridge. All right. So any questions on the treatment? So after let's say the patient completes treatment, what do we do now? Are they good? Okay, so we have to ask for another sputum culture. So the sputum here has to be, because I just said that you can go out, right? Now, notice that there is no, I didn't mention you can go back to work yet. You can get out of the house, but can't go back to work because your employer usually requires 3 negative sputum cultures. So the earliest you can get a sputum sample is about 2 weeks after continuous treatment, 2 to 3 weeks. So that's about So how long could you potentially be out of work? About 6 weeks, because it's every 2 weeks, 2 to 3 weeks apart between sputum cultures. So you need 3 of them. So if you're negative on after 2 weeks, that's just 1. So we need another 2 weeks. But what if you're still positive after the first 2 weeks? Okay, so you'll be out of work potentially longer, okay, depending on how your body reacts to the treatment. All right. Any other question? No, of course you're on, you're on sick, you're on sick leave. Don't worry, you get paid because yeah, as long as you have benefits. As long as you have that in your benefits, okay? So you have sick days, yeah, they'll give you sick days, okay? So since you may possibly
I'm saving the job.
get all your sick days consumed, right? Because that's a long time, 6 weeks. So
Oh,
maybe you'll fall under short-term disability already. It will kick in. Depends on the facility. Yeah, because you have unions, right? So what does your union provide? So maybe they won't touch your sick days. Maybe this will fall on a different benefit. Okay, like COVID, you guys have COVID sick time, right? Correct, yeah. So maybe like that.
So they're retested, is it after the initial phase, like the 2 weeks after the initial phase?
2 weeks after treatment,
So after the-
continuous treatment.
so
Yeah.
after that.
Mm-hmm. We can start because you're showing improvement, right? So you're taking the drug, so your symptoms are improving. So yeah, and then you're eager to go back to work. So we can start testing the sputum again
At
for
2 to 3 weeks on the drugs that they show that
Mhm.
after that 2 to 3 weeks where they're no longer contagious.
that
because
you're
they're taking
taking the drug,
drugs,
right? Yeah.
So then 2 weeks following that. They're
Yeah,
still
we
in the
s-
initial phase.
Yeah, we can start
Okay.
testing your sputum already. Because
Gotcha.
some people, let's say you're otherwise healthy, yeah, you can turn negative at that point already. The other interventions here are not any different from asthma, pneumonia, COVID. Same. Do you still promote airway clearance?
Yeah.
Do you give bronchodilators?
Yeah.
Okay, so can we give you something for the cough? Yeah. So symptomatic treatment, we include that, but the main treatment for TB are those for antibiotics. Adherence, again, I already described DOT. If there is risk for non-adherence, then we'll do what we have to do, right? And here already avoid alcohol. One more thing here. One of the drugs makes oral contraceptives rifampin. So rifampin can affect the effectiveness of OCPs, oral contraceptive pills. So what do you use while on rifampin?
Abstinence. Abstinence.
In the real world, okay, so what can you do? No, rifampin is 6 weeks. No, 6 months.
You abstain for 6 months.
Again, in the real world, what will we do?
Pull out.
Because this will not work. Okay, so use alternate. Okay, so encourage your patient and the partner to use an effective alternate form of birth control. So here's the DOT. That's not Department of Transportation. Okay, that's direct observed therapy. DOT. Any question on pulmonary TB?